Thank you for reconvening so quickly. Hopefully breakfast was okay. So it gives me really great pleasure to get to introduce our next speaker. So Dr. Mikhail is a board-certified psychiatrist coming to us all the way from Pittsburgh, just a hand right next to him. Good friend of mine and really an expert in this particular field. And that's why I'm so glad that he got to be with us today. So Andrew graduated from the University of Miami, did residency in Case Western, and he's currently working in what's called an Assertive community treatment team, which he'll explain more what that is. But we think of them in the psych world as like the heroes, right? Those are the guys that you need someone who's gonna not just sit in the comfort of your office, regla, and the patient will come to you. No, Dr. Mikhail goes in the streets and really finds the patient and really is, I'm just talking about a little bit, okay. And is really engaged with the patient on a different level. So we're so happy that he's with us here today. And please help me welcome Dr. Mikhail.
Everyone hear me? I think we fixed the microphone situation. Lower? Okay. Good? Can you hear me now? Good. Okay. All right. So thank you, Mina. I mean, those words are not really necessary. But so like you said, my name is Andrew, or Dr. Mikhail, or Dr. Mikhail for my American folk. So I'm a community psychiatrist, but I work on something called an ACT team. Has anyone heard of an ACT team before? Yeah, the psychiatry pharmacist, yes. Okay, so ACT teams are, I work on a group of professionals who are social workers, nurses, someone who specializes in forensics, someone who helps with jobs, someone who helps with drugs and alcohol. So we work on a team of about 12 to 13 people, and we go and see people in the community. So the referrals that we get are very poorly functional patients. So what we're going to be discussing today, bipolar, schizophrenic patients, who just have such severe impairment that they refer them to our team to help with reducing hospitalizations, because a lot of times these people are high utilizers of the hospital, meaning they're in and out of the hospital a lot, or they cost the system a lot of money. So what they do is they refer them to this kind of ACT team. So I'm the psychiatrist on the team, and we see these people in the community. So what we do is we see them at their homes, on the street, wherever they are, and we find them. And we make sure they're taking their medications, and we'll talk about the compliance issues and everything in a minute. But we make sure we keep them out of the hospital, we keep them out of jail, we get them functioning back in life, and we try to get them working again. So that's the ideal goal of the ACT team. It's a very fun job. I love what I do. I love psychiatry. That's why I'm here. And I love our church, and that's another important reason why I'm here, to kind of talk about all these different things. Another fun fact, so I have a little bit of a special background. So my father is a priest, my mother is a psychiatrist, and my brother is a psychiatrist. So we have our bases covered in our church. So we help out my dad a lot with a lot of different situations, issues. And then on top of that, I actually have a cousin who's a psychiatrist here, actually lives 20 minutes away. She lives here in Jersey. So a lot of psychiatrists in the family, so I don't know how you take that, but here we go. So these are just some of the kind of objectives. So some of the objectives that we're going to be looking at. What is serious mental illness? What we call SMI. We're going to be discussing more about bipolar disorder, schizophrenia, and how to engage people, especially in our community, of getting help, getting treated, and finding the right resources. And if you excuse me, I'm getting over a cold. I just came back from Africa. I hope I don't have corona. I probably don't. But everyone is scared of me, so they've been keeping a kind of a short distance from me, just kind of a handshake away. But I am getting over it. But excuse me for my congestion and everything. All right, so we're going to start first with the case here. So Mina, 25-year-old Coptic guy, has been coming to church over the last several months, and you notice something different about him. He's been acting more isolative. He's been not really bathing as much. Beard is more hairier than usual. You closely pay attention to him during the waza while Abuna is speaking, and you notice that he's talking to himself. You later ask him, who are you talking to? He starts talking about multiple people talking to him in his head and having conversations, but he wasn't able to, talk much about this. He then goes on to talk about how there's also cameras at his home, and there's people, the FBI is trying to watch him. So just to kind of start off, so what is this person suffering from? So who thinks this person is suffering from bipolar disorder? Okay, good. Who thinks this person is demon possessed? Yes. Okay, a couple hands. Who thinks this person has schizophrenia? Yes. All right. Who thinks none of the above? This is a normal Coptic person. I need some hands up. I need some hands up for that. Okay. I know there's uncles in the church. You see them popping up. All right. All right. Case 2. So keep these cases in mind. We'll go over them after, and hopefully you'll get something out of the talk. Case 2. 30-year-old Coptic girl named Mary has been acting more bizarre lately. Notice that she has not really been sleeping much lately. She feels like she is on, quote, top of the world and so full of energy. You start talking to her, you notice that she's talking really fast, going from topic to topic. You're not really able to interrupt her. You later find out that all of a sudden she decided to quit her job because she had been reincarnated as Saint Mary, and she's here to preach, I spelled you wrong, sorry, to preach her son's name. Okay, so again, what is this person suffering from? Who thinks bipolar disorder? A lot of hands, okay. Who thinks demon possession again? How about schizophrenia? Some people, okay. None of the above, this is still normal. This is still something I experience every day. My last question here. So what has the strongest inheritability? This might not be as easy. What has the strongest inheritability of the mental illnesses? So inheritability meaning that the most genetic component. Okay? Who thinks A, bipolar disorder? So 1, 2. Demon possession? I think so. I'm gonna put my hand up. 3, schizophrenia. Okay, some hands. 4, major depressive disorder. And 5, anxiety disorder. Okay, so a lot of people were scared to vote. That's okay. That's why we're doing pre-test, so we can learn something today, okay? All right, so let's start with the first definition here. Serious mental illness, or SMI. So I'm going to be using the word SMI because, let's be honest, serious mental illness is a lot to say in one sentence. So serious mental illness is a mental behavior or emotional disorder resulting in serious functional impairment which substantially interferes with or limits more than one major life activity. What does that mean? So things like, serious mental illness could be schizophrenia, for example. It's very, very impairing, very hard to deal with. They have very poor functioning. Bipolar disorder, again, as you'll see, we'll talk about, very impairing. They're not able to function. These are the people that are on disability. Severe depression. We'll talk. There's going to be more talks about depression later, so I won't go into the details of that. But severe depression, which is can be very debilitating. Severe PTSD. So these are all examples of serious mental illness. So this is all from the NIMH, which is the National Institute of Mental Health. This is where I'm getting some of these statistics from. So what do we know about serious mental illness? So in 2017, there was about 11.2 million adults aged 18 or older with serious mental illness. And this represents about 4.5% of all U.S. adults. So Mina was talking about how depression was the most debilitating and the most reason for impairment and disability. This is just to kind of show you that the people that have serious mental illness, how many that encounter. Okay, so we have 66.7% of those people received treatment in the last year. So about 2/3 of them actually received treatment for this mental illness. And we'll talk about the severity of these mental illnesses and how important treatment is. So this is a good number, but it's still not enough. It was higher among women, so this is common. More women are more willing to go get help than guys. Guys are too macho, they don't want to go get help, they think they're fine. They're too scared to talk about their feelings. How many women know what I'm talking about? Guys are not scared, guys are scared to talk about their feelings? Yes? Okay, all right, I got some heads. All right, so the most prevalent was in the adult age group of 18 to 25, and then the people with 2 or more races. All right, so let's start with bipolar disorder. Does anyone here know someone who has bipolar disorder? Coptic or not? Does anyone know anybody or seen somebody who has bipolar disorder? Okay, most people think they might have seen somebody. Who thinks they might have seen someone who's bipolar? Yeah, a lot more hands for that. Okay. So we're going to talk about some of the facts about bipolar disorder and kind of what the actual diagnostic treatment, the diagnostic criteria is, so that you can kind of recognize that it's more than just someone who's mood swings. He has mood swings, okay? All right, so just some facts about bipolar disorder. So there's an estimated lifetime prevalence of about 3.9%. So this ranges from 1.5 to 6%. It's hard to kind of get the exact number, but this is the statistics from the NIMH. So there's a very high mortality rate in terms of suicide. So 25% of bipolar patients will attempt suicide, and 11% will complete suicide. So do you guys understand the difference between attempted and completed? So attempted is that I overdosed, it didn't work, I went to the hospital, I was fine. Completed is I actually died. I overdosed and died. Or I hung myself and died. So 25%, which is a very, very high number. So a quarter of bipolar patients will end up attempting suicide in their lifetime. So the reason why I'm addressing these issues is this is a very high number. And it's important for us to acknowledge this so that we understand that this is something serious, that we need to get someone help if they are suffering from this issue. And 11% completing suicide is even a higher number. Increased rates of jail time. So we see this a lot in our population. That's why we have a forensic specialist on our team. I've actually had to go to court sometimes too to testify, like, hey, it's just a mental illness. We'll take care of them. It's gonna be fine. And you'd be very, very surprised at how many mentally ill patients are taken advantage of in the jail population. There's so many times. If they didn't have us to advocate for them, these people would be in jail for years, and they don't have anyone to advocate. Luckily, some of these people have us on their team, and we go to court and we fight for them and say, look, this person is not competent. They didn't understand what they were doing was wrong. They were unmedicated. They didn't understand what they're doing. And then what happens is they go to jail. They get even worse treatment. They don't get their, they don't get their medications. They end up getting more behavioral. They get more in trouble with other people, and then they end up staying in jail even longer. So increased jail times, that goes for bipolar disorder, and we'll later find out for schizophrenia. And now listen to this statistic. 82.9% have a serious impairment, meaning that they're low functioning, they're not able to get out of their house, they don't know how to function in life without medications, without proper treatment. And 17.1 have moderate impairment, so meaning that 99.9% of these people have at least moderate to severe impairment. So that's why we call it a serious mental illness. So we're going to see later that these conditions are very, very serious to talk about so that we can get these people the appropriate treatment. All right, some more facts. So bipolar disorder starts on average of age 18, but this onset can be anywhere from 18 to 44 years old, but the highest rates are usually between 18 and 35. Males and females are equally affected, so yes, males are just as affected as bipolar disorder as females are. There's no that females are more, males are more, they're both equal. And there's no clear association with race or ethnicity. So guess what? Just because you're Coptic doesn't make you immune to it, right? So they found that all these different studies around different geographical areas, they have found no association with this, like United States have increased rates of bipolar disorder versus Egypt versus what other countries. All right, so what's the cause of bipolar disorder? So there's a lot of different theories. Again, I think this is why some people have a problem with psychiatry, is that there's still a lot of research going into this field. There's still a lot of things that we don't clearly understand. And as doctors, we need something, right in front of us. We need a lab result telling us this. We need, MRI results. We need CT scans. We need something to tell us that this is something that I know is true. But unfortunately in psychiatry, we don't have blood tests. We don't have imaging. We have a lot of studies showing different, abnormalities and genes and this and that, but we don't have, unfortunately, studies. And this is why some people might have a problem with psychiatry. But there are a lot of different studies showing problems with inheritability. So bipolar disorder is the one that has the most, if someone has a family history of bipolar disorder, they're at higher risk for developing the bipolar disorder, and this is the mental illness that does have the strongest inheritability. So risk of First degree relatives, about 9 to 10%. Anyone, so if a twin has it, so they did monozygotic twin studies. So monozygotic means that these are people that come from the same egg versus dizygotic is 2 eggs. So they found that if one twin has bipolar disorder, the risk of the other one having it is about 40 to 50%. So it's a very, very high, and then you look at the heritability, meaning that how much of this is related to genes, 80 to 85%. 80 to 85%. So it's a very, if someone has this is why any bipolar expert will tell you, always ask for family history, because this is a contributing factor to making the correct diagnosis. So there's been several genes studied, there's been several genes found related to the disorder, but again, there's nothing that's diagnostic to making the right diagnosis. We also have different theories about catecholamine, so it's a chemical in your brain where they think that that's related to the mania, where they have increased catecholamine. There's theories about norepinephrine, there's theories about serotonin. All of these are different chemicals in your brain that our medications work with. So they're still, again, not clear. One hypothesis for the specific diagnosis, but there's a lot of things that they're finding in our brain chemistry and our brain structure to contribute to the bipolar disorder. Lesions in the frontal and temporal lobes. So the frontal lobe here, temporal here. So they found different lesions. The temporal related to bipolar disorder. They found that lesions on the right frontal lobe more related to depression, left frontal lobe more related to bipolar disorder. So they are doing more and more studies again, but we don't have diagnostic studies such as MR imaging or gene studies to show us that this is what it is. And then circadian rhythm desynchronization, this is what we'll talk about again with the sleep disturbances with bipolar disorder. All right, so let's get to the diagnostic criteria. So DSM-5 is, has anyone heard of the DSM-5? Probably the mental health professionals, yeah. Okay, so DSM-5 is like the Bible of psychiatry. Okay, so this is where we can put on all of our labels for everybody. Okay? So this is the DSM-5 diagnostic criteria so bipolar disorder actually has 2 types, but we're referring mostly to the bipolar 1 disorder. Bipolar 2 is just similar, but just a little bit different. So bipolar disorder is they don't necessarily have to have depression. So as part of most of the bipolar disorder patients do have depression, but the only diagnostic criteria is they have one manic episode. And we'll talk about what a manic episode entails. But they actually don't even need the depressive disorder. In bipolar 2 disorder, yes, they do have to have a major depressive episode. But bipolar 1 disorder, they don't have to have it. Most of them do, though. So it's abnormally persistent, elevated, expansive mood. So this is lasting for about a week. So we're not talking about, I feel energetic one day and then the next day I'm fine, I'm dead. Or I feel like I just had an energy drink and I'm ready to just, go crazy. So this is elevated, expansive, irritable mood lasting for 1 week. All right, so we'll talk about the different symptoms that are also related to that. So they have to have 3 of the following symptoms for this week, in addition to and one of them has to be the elevated mood or the increased activity. But if it's irritable or irritability, they have to have 4 of the symptoms. So inflated self-esteem or grandiosity. So if you look at what we talked about, they feel grandiose, meaning that they feel on top of the world. They have grandiose delusions of I was reincarnated as Saint Mary, and I'm the king of the world, and I'm gonna take care. I came down as Jesus Christ, and I'm going to cure the people of AIDS and whatever. So they have these grandiose thoughts. They feel on top of the world, and they feel like nothing can stop them. They feel unstoppable. Decreased need for sleep. So this is always my initial question for people, because I have found this with all of my bipolar patients. Decreased need for sleep. So I always ask, what's the longest you've gone without sleeping? Oh, I sleep every day. Okay, we'll scratch that. Okay, so decreased need of sleep. Most of these people will not sleep for a week at a time, at least. So that's part of the criteria. They won't sleep for a week at a time, or they'll sleep like 2, 3, 4 hours, and they're ready to go. They're on the go. They're ready to just take over the world. So they have this decreased need for sleep for about 3 or 4 hours, or they won't even sleep. Some people won't even sleep for weeks at a time. So this is all, again, some of us have had those issues where we don't sleep for a week. Doesn't mean you're manic, but this is all going together as part of the diagnosis, together with these other symptoms. All right? More talkative than usual, pressured speech. So they'll start talking like this, and you can't interrupt them. They'll go from topic to topic. They're what we call flight of ideas, where they go topic to topic. They can't interrupt them. They're just talking so fast. And again, this is only during that time where you're having increased energy. You're having that expansive mood. You're not sleeping. This is all going together. It's not like, because there's people that talk fast. They don't have bipolar disorder. There's people that talk fast at baseline. How many of us have a friend that you just like, slow down, stop, calm down? Some people talk fast at north baseline, but this is distinct behavior that's different from their normal behavior. So this is a distinct period of time where they're different than, and I've seen people that are just, it's too much. Like you have to like basically cut them off. Like you really have to push yourself in, because they will keep going. All right. So again, we talked about the flight of ideas, racing thoughts. So again, they're just moving from topic to topic. They'll talk about macaroni bechamel, then they'll talk about Jesus, then they'll talk about kofta. They'll just keep talking from going from topic to topic. Distractibility. Again, this is something where they're like, okay, they'll start talking to you, then they'll go talk to this person, then they'll go talk to that person, and they're just moving around. They're just at an increased rate of functioning. They're just going fast. Increased in goal-directed activities. So again, they're doing things that they normally wouldn't do. They would clean the house more. So they'll be up for days cleaning the house. Again, all of this is together, not separate. So some of us will clean the house for days. That's fine. It's okay. Just sleep. All right. So they'll have increased goal-directed activities. So they'll do more things. They'll finish like 7 books in 3 days or whatever. They'll do more things that they're not normally doing. Again, this is all different than what they normally do. Increase in activities related to consequences. So speeding, like they're driving, they just bought a brand new Lamborghini with money that they don't have, and they're speeding across, and they're getting in trouble, they're getting tickets. They're having sex more, which they normally don't. They will have increased sexual activity. They'll increase in drug activity. Again, this is not normal behavior for them. And this is all causing a significant impairment in their life. So bipolar 1 disorder is, as we mentioned, 89% of these, or 82% of these people have a severe impairment. So these people are all causing themselves harm in the sense that they are not able to control some of these behaviors, and the majority of these people will end up in the hospital in their first manic episode. That's a typical question I ask. How many hospitalizations have you had? Because the majority of the time, if you have bipolar 1 disorder, you will end up in the hospital, especially if you've had a manic episode. And if you ask these people who have had manic episodes, most of the time I don't even have to go through this criteria. They spit it out for me. And that's how you know this is real or not. Because it takes on average, how many years do you think it takes on average to diagnose bipolar disorder correctly by a psychiatrist? How many years do you think? Throw out numbers. Throw out numbers. 5? 3? What? It takes on average 8 years to make a correct diagnosis of bipolar disorder. Why is it so hard? Because unless you see a manic episode in front of you, it's hard to diagnose it. Because again, how many of us have had days where we don't sleep? How many of us have had days where we're in cleaning the house, abruptly, or we just have a little bit of a change in behavior, but not really? And most of the time, bipolar patients are in the depressive state. They don't have to have depression, but most of them are in depressive states, so it's hard to, the manic episode will come later. So it's hard to make this diagnosis for psychiatrists, not let alone, primary care doctors and everything else. But it is a hard diagnosis to make, and like I said, we don't have we don't have a blood test that says this is bipolar disorder. We don't have imaging. So, it is something that we should try to catch early enough, but also get these people help, because you can see how it can impact someone's life. Okay? Any questions about, yeah?
What I've seen is, I'm a therapist, what I've seen is if you give someone who has bipolar, because they're usually depressed,
Mm-hmm.
if you give them an antidepressant, perhaps the antidepressant
Yeah.
spur on
So this is why it's. Did you guys hear the question? So she said that as a therapist, she sees people who, if you give a bipolar patient an antidepressant, sometimes it triggers a manic state, and this is correct. It happens in about 30% of patients. It's still high, but it's not. It doesn't happen as common, but it's still high, and that's actually in the DSM-5 they made it a criteria that this is criteria for bipolar disorder. But that's why it's very important, because guess who do you guys think is the people that prescribe antidepressants the most? What do you guys think? Who? PCPs? Who else? So yeah, so primary care doctors actually are the ones that prescribe the most antidepressants. Who was surprised by that? Anybody? Yeah, so like Mina was saying, that they are the front line. A lot of people don't want to go see a psychiatrist. They don't trust a psychiatrist. They don't. They feel like they had a bad experience, or they feel like they don't want to be on medications because of the stigma, because of God knows what. But the primary care doctors are the front line. So it's very important that they rule out a manic episode before starting antidepressants, because it can cause them to go into a manic episode. And that's where usually people, when they commit suicide, they're in their peaks or valleys. So when someone's in an extreme manic episode, that's when they'll usually commit suicide, or when they're severely depressed. As part of their depression, they'll attempt suicide. Any other questions about bipolar disorder before we move on? Yeah.
Sorry, I'm sure I can Google it, but just an overview of what is a manic episode? What am I looking for? Or how does that person behave, or give me the signs that they're having a manic break?
Oh, that's just kind of what I just went through.
That's all of that.
Yeah. Maybe I'm not doing a good job.
Clearly not a medical professional.
Sorry. So that's exactly the criteria. I literally listed the criteria for a manic episode. So again, the racing thoughts, the not sleeping, and this is all together. Racing thoughts, not sleeping for a week, at least a week at a time, if not a few weeks at a time, or decreased need for sleep. And the decreased need for sleep is because they have so much energy, not because they might have nightmares from PTSD, or they have depression or anxiety. Anything can cause decreased need for sleep, but you ask them and they say they have decreased need for sleep because they have so much energy. So decreased need for sleep, expansive mood, they feel great, they feel on top of the world. And guess how hard it is to treat someone who feels on top of the world? It's very hard. And that's why they always end up in the hospital, because they don't want treatment, because they feel so good. Decreased need for sleep, flight of ideas, pressured speech, talking fast, distractibility, irritability. So those are all, if there's symptoms together for at least a week at a time, and most of these people will probably not end up coming to your office. Most of these people are kind of out on the street, having a great time. And that's why it's so hard to treat these people, because they feel so good about it. They feel great. They're able to do so much stuff. They don't need sleep. So that's why it's so hard to treat them, but it's also very important because they can also do dangerous things that can get them killed or hurt someone else. Sorry, maybe I should have done a better job.
No, that's okay. I'm just putting it all together.
Yeah. So that's kind of the summary of that. Yeah.
Is there a prognosis benefit to early intervention of bipolar and schizophrenia?
Yeah.
You mentioned it takes 8 years
Yeah.
to get someone treated. The people who get it after 1 year or something, do they end up doing better? Or not
Of
really?
course, yes, of course. And the question was, do people who get early treatment end up with a better prognosis? And that's absolutely yes. And I'll show you kind of the studies with that, with schizophrenia. But anytime somebody has an episode, whether it's a manic episode, whether it's a depressive episode, whether it's a psychotic episode, and I'll show you more with schizophrenia, it damages the brain. So imagine, your brain is firing so many signals, your brain can't handle that. So it actually causes structural damage, specifically in schizophrenia, and I'll actually show you what that brain imaging looks like, but it causes structural damage, and every time they don't get treated, it causes that much more damage, and it makes it that much harder to treat. And that's why we have these long-acting injectables. So 70% of my patients are on long-acting injectable medications, kind of like people who have like the depot birth control. We have those for psychiatric medications, especially for schizophrenia. Because these people are non-compliant with medications, and once they feel better, they feel like, hey, I don't need this anymore. Let's go back to the party, you know. But absolutely, early intervention, and they actually have these programs, again, more related to schizophrenia, about these first programs, where it's first break, where they get these people early interventions, and they live, like I said, I work on a team where, you know, it's shown that in these kind of models, 80% of these people can work, which is, by themselves, it's like 20%. But you can create an environment for these people where they can, if they're compliant with medications, you give them early interventions, they can live full functioning lives. Most people, just like everything else, we do have refractory cases. Just like someone has refractory hypertension or diabetes, we have refractory cases of bipolar disorder or schizophrenia. But the earlier intervention, the better, because of the damage that it does every time you have an episode. Any other questions about bipolar disorder? All right, let's move on to schizophrenia. So who knows someone who's schizophrenic or knows somebody who may be schizophrenic? Anyone seen a schizophrenic patient before? So a few hands. Yeah, some majority haven't. So schizophrenia is even more debilitating than bipolar disorder. So they have even more impairment because of the nature of the disease. And it's basically, they just live in this kind of altered reality. So we'll talk a little bit about the facts about that. So just FYI, you know, I know Coptic people who are bipolar. I know Coptic people who are schizophrenic. I know Coptic people who are depressed. I know Coptic people who are borderline. I know Coptic people who are cutters. There's a lot. So just to give you an idea that we are not, as the Coptic community, we are not immune. We are protected by our religious faith, and that our faith is a protective factor for a lot of illnesses, but we are not immune to these illnesses. These things affect us just as much as, you saw how many people suffered from SMI, 11.9 million, which is 4.5% of the adults. That includes Coptic people too. We're not just in a special bubble. So a lot of Coptic people are suffering through this, and we'll talk about how we create an environment where they feel comfortable getting help. Okay, schizophrenia. So let's talk about the prevalence of it. So again, it's not a common thing. It's common for me because I see it every day, but it's not a common thing. It's 0.6% to 1.9% in the US and 0.3% to 0.75% internationally. Age of onset, again, most of these serious illnesses happen early on. Late teenage years, early 20s. So schizophrenia for males, it's about 18 to 25 years is when the typical onset is for a schizophrenic male. And for females, it's 25 to 35. So a lot of times when people are hearing these, are like, uh-oh, there's still time for me to get it. No, so again, we'll talk about also the inheritability. This also has a strong genetic component to it, and we'll talk about that in a second. But this is the typical age of onset. So we're going to be talking about some of the imaging studies. So over 100 studies showing structural abnormalities with patients who have schizophrenia, mostly enlarged ventricles in the third and lateral ventricle. Doesn't mean much to most people, but I'll show you what the actual brain studies show in terms of a patient who is schizophrenic versus someone who's normal. Again, these things are not diagnostic for us, but it has been shown and seen in studies that this is what happens with these patients. And there's it's a little typo, there's over hundreds of genes that have been associated with the disease, but again, not diagnostic for us to say that this person has schizophrenia, okay? All right, so this is what the brain imaging looks like for the unaffected patient on the left and the affected patient on the right. So it's pointing, it's what they call in radiology the arrow sign. So this is where the defect is. So it's showing you the enlarged, the schizophrenic brain. This isn't monozygotic twins, meaning that they came from the same egg. So this is what it shows, that it shows the enlarged ventricles in a schizophrenic patient over time. And as you have more and more psychotic episodes with someone who's not treated, these ventricles become larger and larger due to basically destroying your brain. So because it's so impactful on the brain, it ends up causing more and more volume loss. So you'll see patients with schizophrenia have a decrease in brain volume over time, and if they're not on the proper treatment, if they're not compliant with medications, it only gets worse. And because if it gets worse and they have more damage, it's harder and harder to treat. That's why it's so important to get these people early help, to get them treated, because they really can live functional lives. And I see it every day with these people that said that they were in state hospitals for years. So they were trying to close down these state hospitals and create more of these ACT teams. These people were in state hospitals for years, thought they would never live on their own again, thought they would never work or function. And most of them, I would say most of them, are now functioning and taking care of themselves on their own and working. So it is something that if you get early intervention, you get them treated, and that's why they have these long-acting medications now. So there's medications that stay in your system for 3 months. It's an IM medication, so literally I've done injections in cars. I've literally found people on the street. I found people on the street, and I said, get in the car. Because it's so important about compliance. Compliance is so important, you're at risk of them having more and more damage the further they're not compliant. So it makes it harder for treat. So I can't stress enough how important it is to get early intervention for these patients. So just a few more facts. These patients are at higher risk for violence. Specifically if they have voices telling them to go hurt somebody, voices telling them to go take down President Trump. Sometimes the FBI gets involved with those. We have a patient that actually, she literally calls, the FBI knows her by name because she calls so many times every day, 30 times. So they're at higher risk of substance use. This is a big one. So high comorbidity with these illnesses, because they use other things to kind of take them away from these voices, take them away from these delusions that they're having. And it could even worsen their delusions and voices. High risk for suicide, so about 5% of these patients will kill themselves by suicide. This one really hits me hard. Average loss of 28.5 years. So what does that mean? So person who has schizophrenia or bipolar disorder, this is specific to schizophrenia, but goes along with all mental illnesses. Someone with schizophrenia will live 28 years less than an average person because they end up having problems where they're not compliant. These people end up on the street because of non-compliance, poor functioning, brain damage, and they end up not having anyone to take care of them because their families can't take care of them, or they're sick of taking care of them because they are so overwhelming to deal with. So that's a big number, 28.5 years. That's a big number. And the most common reason for death actually is heart disease. Financial costs. So this is, again, why they've created some teams like the ACT teams, because they cost the system a lot of money. So think about someone, if someone is mentally ill, they're not going to take their blood pressure meds, they're not going to take their diabetes meds, they're not going to take their cholesterol meds. And what ends up happening? They have heart attacks, they have strokes, they have all kinds of different physical manifestations of non-compliance with their medications. And guess what? Most of these people are lower socioeconomic status. They're not going to pay for their hospital bills. They're not going to, they're not going to be able to afford medications. They're not going to be able to take care of themselves. And this is what causes the system and the family, not just the system, but the families, suffer a lot financially. All right, so what do we know about the causes of it? Again, a lot of different theories, a lot of things that they have found associated with schizophrenia. So the first one's in utero, so obstetrical complications, maternal intrauterine bleeding, infections. They found that someone who has the flu. It's not to scare any women out there who are having kids. These are just things that they have found associated, especially for some reason the flu. But these are things that they found, because in the end it kind of just triggers different markers to be turned on or off, and the stresses on the different parts of the genes are the ones that get turned on and can cause these different issues. So genetic, again, this has a very high genetic component. So monozygotic twin studies, they've shown that 48% of people who have a twin with affected, they'll have, the other twin will be affected, about 48%. So if both parents are schizophrenic, there's about a 40 to 60% inheritability factor. It's still stronger with bipolar disorder, but with schizophrenia, there's about a 40, if both parents are affected by schizophrenia, there's about a 40 to 60% chance that the child will develop as well. And then environmental. So childhood trauma, again, any stress on the body that triggers different genes to be turned on or off, can cause someone to be higher predisposed to schizophrenia. Living in an urban area, social isolation, chronic marijuana use. I want to touch on this one. So there has been studies showing that someone who might be at predisposition to develop schizophrenia can actually develop schizophrenia with chronic marijuana use. And what does chronic marijuana use mean? Starting at the age of teenage years. So when they're early on, they're 13 to 15 age group. So anyone that has a higher predisposition to developing schizophrenia, or even if they have a lower one, and someone is predisposed to developing schizophrenia, chronic marijuana use can push them over the edge to develop schizophrenia. There's been several studies showing that. Yeah.
Wondering about the residents in urban area, like is that because of related to the childhood trauma, or is that like on its own? What is it about living?
I think it's more of the different, it's more related to the childhood trauma. I think the different education, the different ways people are brought up. That's I think where again, it's any kind of stress on the child as a development, in their development, can cause some of these predispositions to be higher. But yeah, the marijuana use is the one I wanted to really focus on, because people just think that marijuana is something that I can just, use all the time, there's no problem to it, and, there's nothing wrong with it. Now, it doesn't directly lead to schizophrenia, but it's in people who are predisposed to developing schizophrenia. So as you can tell, there's a high inheritability factor with schizophrenia, is, again, along with bipolar disorder, where people can have the inheritability of this is also up there about 80%. So the 80% meaning that these genes are related to them developing, their genes are related to them developing schizophrenia. So this is something I wanted to stress, especially with a lot of us are servants, a lot of us have kids who are smoking marijuana regularly, and they just think it's fine, it's easy, and it's becoming a regular use, like daily use. We're talking about daily uses of, smoking every day. So that's just something I wanted to kind of emphasize. Any questions about that before I move on to the criteria? Yeah.
Sorry, so when we have young people in our church who say, well, this is chronic, regular use, and I can use it once in a while, what would be your response to that?
I mean, are we talking about in the church and what I should say, or actual effects of it? So, yes, we should always discourage. I'm sorry? Both.
I'm actually curious because you said that, you said that for a reason. What do you think is usually, I think our youth, we have to be realistic, our youth are doing this.
Yeah.
And they're doing it because they'd rather do that than actually go and get some help for their anxiety.
Yeah.
They would rather.
Right.
So, in the context, if this comes up in it's not going to come up in a small group context, but maybe one-on-one counselors
Yeah.
in the church.
Right.
There are people, you're a professional, so you can give a lot of those facts, and
Right.
they'll take it as
Right.
so. But if there's a servant who's not a mental health professional who wants to convey a balanced perspective that doesn't mean that's not too parental,
Yeah.
but that addresses that, how would you go about doing it?
So I would mention this factor. I think with any kid, their brain is so fragile, and their brain. And I just came back from Namibia actually, in Ethiopia, and we were giving a lot of talks because their rates of suicide, addiction, sexual assault was increasing, and so the Ministry of Health there wanted us to address these issues with the different schools. So the biggest thing I told them is, these things with kids, the brains are developing until their mid-20s. So people, I always tell them, your brains are forming these signals, they're forming these connections, and if you introduce any mind-altering drug, whether it's alcohol, whether it's marijuana, whether it's any kind of drug that alters the brain, you're altering the way that your brain is developing. So I tell them all the time, long-term effects of alcohol. You know, no one goes into addiction saying, yes, I want to be an addict. No one goes into that. Most of the time is I started drinking on the weekends, I started drinking every day, started drinking multiple times a day. Marijuana is the same thing. So I tell them, any mind-altering drug will cause problems in your brain development because your brain is so fragile right now and it's still developing. And that's why kids are at high risk of suicide. Why? Because their brains are still developing. They're impulsive. They don't know how to deal with stress. So what do? Someone puts something on Facebook, I'm going to go hang myself. Because they're so impulsive, because they're still not fully developed. So that's what I tell them about marijuana, alcohol, cocaine, any of those things. Because if you're altering those things, I tell them chronic marijuana use can lead to earlier dementia. It can lead to memory loss. It can lead to different problems with even cancer. I tell them these things because, again, they don't get that. If I told an adult, it'd be different. Adults, there's something that, there's the whole medical marijuana thing, and I've looked into this a lot, and, technically there's not really, technically marijuana has never directly been a cause of death, directly. Indirectly, of course. But when I talk to youth, I tell them, this is something that can develop, and this is something that you can harm in terms of long-term use. You can harm yourself in terms of long-term use of it, and you don't know these things are happening until later on because your brain is still developing at this age. Yeah.
Can I just mention something really quickly? So we know that if you have a history of psychiatric illness in the family, the risks are multiplied if you use marijuana, right? And it doesn't necessarily have to be chronic. It can be a few times if you're already prone. And maybe it's just me, but I feel like, because in the Coptic community, if there's a history of the family, you will never know.
Yeah.
So it's important to mention that most likely our families have some history we don't even know about it. If there's an underlying reason for using marijuana, if you're anxious, whatever, to get
Right.
help and so on. So I know we always talk about chronic use of marijuana, but also in our setting, like in the psychiatric hospital setting, we've had people who've only used it once or twice or 3 times, and they ended up in our hospital because of the family history.
Right.
So there's a lot of
factors.
There's a lot of factors in our history in our culture too, in terms of we don't really label things as mental illness. So you had a weird uncle, you don't want anything about.
Right. And that's true.
So
And
you have to account for that.
yeah, and that's the thing and that's why we don't tell kids it's okay to drink, it's okay to do those things, because again, their brain is so fragile at this point that it's not worth the risks of developing these problems later on in terms of their brain development. So that's kind of the way I go at it, because if you tell them don't drink, don't do drugs, what are they going to do? So you have to be realistic, but at the same time educational. So, for example, I would show, in Namibia, I showed them what a cirrhotic liver looks like, and I left it on the page. I said, this is what a cirrhotic liver looks like, and cirrhotic liver is someone who has a liver failure. Those are people that develop jaundice or like yellowing of their eyes, yellowing of their skin, I showed them really bad pictures of liver failure to show them what are problems that can happen as a result of alcohol. Because the other situation that I always tell kids too is, if addiction is inheritable. So if someone who is father or mother is alcoholic, or someone who is addicted to drugs, they are likely to have, if they get even exposed to one dose or one alcohol or one thing, they are more likely to also develop addiction as well. So again, this is something I always talk to the youth about as well. All right, let's kind of move on, and then we'll kind of take more questions later. So this is the diagnostic criteria for schizophrenia. So it's 2 or more of the following 5 symptoms. There's 2 more on the next page. But they have to have one of these 3. So they have to have either delusions, hallucinations, or disorganized speech. So delusions can be persecutory delusions. So I feel like people are trying to harm me, they're out to get me, you know, they're trying to stab me, you know, people are spying on me. I've heard this from abunas that come and ask me, like, you know, this person thinks that there's a camera in there, you know, this is a common thing, there's a camera in the room spying on them, it's the FBI, it's the CIA, you know, and abuna's just like, did you take your medication? You know, like, so again, these are delusions. They have like other delusions of grandiosity. They can have the, you know, I feel reincarnated as Jesus Christ and Saint Mary, all those things. So those are all different delusions. Hallucinations, these are, you know, they're hearing voices. So voices are, this is very subjective, but you have to understand what common voices are and not common voices. So someone who has schizophrenia, they're having, most of the time they have either male voices, one male voice, or multiple people talking or having a conversation in their head, and they can't tell what's reality, what's not. I have a patient, strongly medicated, and he still like feels like a puppet. So like he always like starts talking to himself, and even though he fully hears what I'm saying, but he still can't. He describes it as like a puppet, like talking for him. And you notice it because he'll be like, you know, like he'll just talk to himself. But then when you hear him, he talks louder when he's talking to you. So hallucinations, like someone who says, like, I hear my names, I hear waterfalls, I hear different things, like those are more sounds. It could be related to other medical things, but hallucinations are more of like, and most of the time, the most common hallucination is auditory hallucinations. They do have visual hallucinations as well, but most common is auditory hallucinations. Visual hallucinations are more related to like when someone's medically sick, we call it delirium. So they're in the hospital, they're medically sick. They'll have visual hallucinations, mice running on the floor, little people standing there. That's more related to medical complications, but auditory is the most common for schizophrenic patients, although they still have visual hallucinations as well. Olfactory can be related to seizures. Tactile hallucinations, so people feel like they're tasting things, that can also be related to other medical causes. And then disorganized speech, they just don't make sense. What they're saying just doesn't make sense. And then the other two things, criteria-wise, so they have to have one of these, and then, or they can have two of them, but they have to have two of the five. Grossly disorganized in their behavior, they're wearing things that aren't appropriate for what the weather's like. They have catatonic behavior, meaning that they're just kind of not doing anything, they're not eating, they have the waxing flexibility, like, you know, they stay here for hours at a time. Negative symptoms, so this is why schizophrenia oftentimes is misdiagnosed as depression, because the negative symptoms are, you know, their apathy, they have a blunted affect, meaning that they don't have an expression on their face, so they just like look at you like this, and they don't really smile, they don't really talk much, they're isolative, so it looks like depression, and it's what we call prodromal symptoms of schizophrenia, but those are more of the negative symptoms. Again, this causes, all of these symptoms, all of these diagnoses cause a gross impairment in their functioning. So someone who, you know, someone can hear voices and they can live fine, okay, fine. But it causes a gross impairment, that's when we need to get them help. All right, and these usually last for about 6 months. So these are the symptoms that last for 6 months. Okay? Let me look at my time. So any questions about schizophrenia? All right, I'm going to try to wrap up here in a little bit. So just to kind of, so I'm giving you all this information so that you understand the severity of these illnesses and the importance of getting these people help. You know, depression, again, is one of, and Abuna will talk about that, I think, later, but, you know, someone who's depressed, you know, they might not feel comfortable seeing a psychiatrist. You can give them counseling, you can give them therapy, you know, but these are serious illnesses that need help right away, because like I said, the later you get to them, the harder it is to treat, and then the harder it is for them to live a full functional life. And that's why most of these people end up on the streets. All right? So, is it sinful to be treated with medications? So, I think we're going to be discussing this through all of our talks, and I think all of us are using the same Bible verses from Sirach 38. I just took the first few verses. I'll read it real quick, but I'm sure it will be repeated throughout the day. So it says, honor the physicians because of necessity and because of the Most High created him. For all healing is from God, and so he will receive gifts from the King. The expertise of the physician will lift up his head, and in the sight of great men whom we praise. The Most High has created medicines from the earth, and a prudent man will not abhor him. I'll just skip over. The benefits of these things is recognized by men, and the Most High has given this knowledge to men, so that he may be honored in his wonder. By these things he will cure and mitigate their suffering, and the pharmacist will make soothing ointments, will form healing medicines, and there will be no end to his works. For the peace of God is upon the surface of the earth. Yeah, this is from Coptic Reader. But I think the other translation of it is druggist or something.
I know, I didn't think you'd have a word for it.
Yeah, this is from Coptic Reader. I think they did their own kind of adjustment. But there's different versions of it. But this is clear as day, showing the importance of going to a physician. And it says suffering. It doesn't say physical suffering. It doesn't say mental suffering. It says suffering. These people suffer. These people suffer a lot. Their families suffer a lot. The people, their friends suffer a lot. These people are suffering. And that's why it's important for us to get these people help as quick as possible so that we can serve them. Okay? So how do we make these people comfortable getting help? And this is, I think, a big struggle in our church. We have to make our environment easy for them to be approached to get help. So how do we develop this? Identifying myths revolved around mental health. There's so many times where I have an adult talking to me like, oh, you're a psychiatrist, انت بتاع المجانين. And there's literally a kid next to him who overdosed on medications a week prior to that, and he's talking about meganin and all this stuff. And literally I'm watching, and I see the kid next to him, and his kid has been struggling with depression. He's overdosed several times. He's had multiple. It's Coptic kid. This is Coptic. Several suicide attempts, and then the uncle next to him, because he doesn't know, because we like to joke around about it, doesn't realize that that kid is the one actually who tried to kill himself 2 weeks prior. So it's very, very important that we make it, the church is a hospital. It should be a safe haven. It should be a place where people feel like they can go get help. It's not a place where we go to judge people. How many friends I know, or how many people that suffer from addiction, they don't feel comfortable going to the church. Why? You know, he's a crack addict. The person that he's an alcoholic, civic minimum. How it kills me. It kills me to see this stuff happening. And what is our ultimate goal as Christians? Love. And what kind of love are we showing if we're only showing love for ourselves? We don't want to help other people. We don't want people to come to us for help. We want them to be doing well. Oh, this person is an addict. Let me turn my back to them. This person is, you know, struggling with schizophrenia. He's talking to himself. The Magnun, civic minimum. How many times I've heard that, and it breaks my heart because people are talking about this when the person next to them is suffering from that problem. I've had clergy, no offense, I've had clergy say things in wazas, and then people from the church come up to me or my mom or any of the other 5 psychiatrists in our church, and they'll come up to us and say, like, is it wrong for me to be taking these medications? Like, you see what Abuna or the bishop or whoever has just said. Education is so important, and we have to decrease the stigma because people have committed suicide. Coptic people have committed suicide, overdosed on medications, hung themselves from not being able to feel comfortable getting help. And we have to decrease this as a church. We have to make it comfortable for people. This is what our job is as Christians. Our job is to love these people. It's not to turn our back on them because they're going through problems that we don't want to deal with. Okay? And that's where I kind of go back to education. This is why you guys are here today. You know, we have so many psychiatrists in our church. Sorry. We have, huh? Yeah, sorry. We have so many psychiatrists in our church. We have so many people that have gone through so many trainings and are a lot of mental health professionals. I know psychiatrists all across the country, at least 15 of them, 15 to 20 in different states. And I know, and it's so important for us to be educated on these different topics because if we don't get ourselves educated, then we're going to lose a lot of lives due to mental illness. You know, so this includes church servants, includes clergy, includes everybody, the congregation, talking to families. parents. These are all so important. It's so important for us to be educated. It's so important to educate others so that we, can serve these people right. I had a college kid tell me, one of the servants told him that schizophrenia is not real, it doesn't exist, and it's all demonic possession. And I said, what does that person do for a living? I'm not going to mention this field. I said, that's my point. They don't know what they're talking about. And unfortunately, this is servants, Sunday school servants. So I'm not bashing servants, I'm not bashing clergy, but I'm trying to get at the point that this is so important for us to be educated and to continue talking about this so that people can get the help that they need. All right? Sorry, for sake of time, so again, the first case, you guys will also be good about it, someone suffering from schizophrenia. Second case was bipolar disorder, and then the strongest inheritability, that was bipolar disorder. And I'm just going to leave with this last thing before I end. I just came back from Ethiopia, in Namibia, and they weren't used to psychiatrists going there, so they didn't really know what to do with me. But I kind of made my way and made my own mission trip. And these are actual pictures today, this is 2 weeks ago, of patients, psychiatric patients. So this is a shelter that I went to. It has 250 psychiatric patients in Ethiopia. 250, this was one of the shelters. This is only one. 250 psychiatric patients, and you can see how they're chained. Now, I hear about these stories, but it doesn't become a reality until you see them. And I don't get disturbed by anything in psychiatry. I deal with a lot, but this broke me down. That people are being chained because they're not able to get the help that they need, and they're not able to they have one psychiatric nurse managing 250 intellectually disabled, autistic, schizophrenic, and bipolar patients. One psychiatric nurse. And you can see in both these, this is the first picture is a little girl, she's 12 years old. She has chains on her ankles because they're not able to control her behaviors. This other person, again, intellectually disabled, he's eating garbage, he's eating leaves, and then they wanted to control him, so they chained him behind his back. And then this is kind of the living situation. Sorry, I forgot to get to Abuna about your comments.
I know it's lunchtime before it's even so two notes. I'm not defending the men in black, which I don't, because we are serving somehow. There is some sort of an irrational exuberance between the church and leading to spirituality versus scientific research and R&D. I love the age bracket sitting in this room because it tells me that there's a tendency toward applying scientific research in the church, which makes a lot of sense. We need more and more. We need more clergy on board. I was surprised to see that I'm the only priest attending. I didn't like it, by the way. I hope to see more and more servants, deacons, clergy. Because what you just said happened to me, and I'm just a newly ordained priest. And 11 years old who comes to me like committing suicide is something I will not take. And people resorting to one verse like, hey, your faith has saved you, go in peace. That's not acceptable. But there's a fine line between using spirituality and using only scientific research. That balance needs to be created in the church. Thank you for this. It helps a lot. I'm happy I'm here. What I really want to focus on for the future, get into more servants attending those events. Because this is the only way forward. If you rely on people, or I don't want to get into the details of politics because that's going to help me. More and more.
Yeah.
But like,
And
not just resort to one thing to do one way things.
Yeah.
It's not right.
Yeah.
Especially in the church.
Yeah.
Because hey, I want you listen to me.
Yeah.
See?
I wanted to emphasize, I didn't have a lot of time to talk about, the importance of also these servants in our clergy, because these are the front line that we mentioned. These are the front line of where these people go for help. And it's important for these servants, as a servant, as a clergy member, it's important for them to go to you and feel comfortable going to you. Because if you tell them, go in peace and the peace of God be with you, they're not going to feel comfortable talking to you. They're not going to be, they're already embarrassed about what they're going through, and you're making them more embarrassed by you being embarrassed about it, saying, this is not, this, pray and it will get better. And I'm not taking away the spiritual aspect of this. The spiritual aspect is a very strong component of someone recovering from their mental health. Very strong component. They need that spiritual guidance. They need that spiritual help. They need that guidance from their servants, from their priests. That is very, very important. I'm not taking away from that at all, because that is something that is very strong in terms of recovering from their mental illness. Like we talked about, the biopsychosocial spiritual model. Medications, I always tell all my patients, medications is one aspect of it. There's a whole other aspect of physical health, exercise, diet, nutrition, religion, spirituality, Christ. There's a whole, these all are the things that are going to help you recover from this. Medications are a part of it. It's not, it's one specific part. But the clergy and the servants, that's why it's so important for us to educate. Because all these things that are said on social media, wazas, they can be very damaging to people. It can cause a lot of problems with people who are on these medications and you don't even know about it. So be very careful of how you address these things, how you talk about these things in the church. I know sometimes it's easy to joke around about these things, but you don't know if the person next to you is getting help for these things. You will never know. As soon as I became a psychiatrist, it's like a flood of all these things that I started understanding about different people in our church, churches across, I get calls from everywhere. Bishops call, priests, they come to discuss different cases. So you don't know people who are getting help, and so it's very easy to kind of make fun, but that is the point of what we're here for, is to kind of decrease this stigma, decrease the comfort and the safe haven of the church. Because believe it or not, there's people that don't feel safe in our church, and that's a problem. That's a big problem, and not just with mental illness, with a lot of it. Okay. So we need to fix those problems. We need to create this environment, because the church in the end is a hospital. It's not he didn't come for the people who are well, he came for the sick. And everyone who is sick deserves to be treated like they are going to a church where they feel safe. All right, sorry I talked too long. Here's some resources, great websites you can go on. You'll get these slides. And then my email here, if you have any questions, you can email me or call me. It's my dog, Stella. All right, any questions? Sorry, it took too long. I know I'm between you and food. Any questions before I go? I'll be back for the question and answer, but. Any questions? Sorry.
I'm just wondering when it comes to schizophrenia and delusions. I've had someone who's opted have very spiritual delusions. And at first they sounded legit, because it's seeing angels and saints were appearing. So I'm just wondering, like for priests or servants or just lay people like us, how do you distinguish, but also how do you convince them to get help when they feel like it's a strong connection with God?
So the way the question was is there's some people that that have very strong spiritual delusions of whatever they might have, and how do you convince them to get help or not? So like I said, I always go back to the functioning. Is this person functioning in their daily life? Okay, is this person now, and that's kind of how we distinguish. Is this someone who's just a very spiritual person who does have that relationship with God, does have that relationship with the saints? Or is this someone who is very delusional? So you have to look at each case by, again, has this person been a spiritual person their whole life and they decided, they have that connection with God? Or is this someone that all of a sudden, day one, they're just like, I did this or that or whatever? I always go back to function, because it is very hard to get people to get help. And especially if they don't feel safe coming to the priest, coming to the servant, coming to the church. So the biggest thing is I always stay connected and engagement. Mina was mentioning engagement. There's so many of my patients that don't want to take medications. And after a year, finally, then they're like, okay, I'm gaining their trust, letting them know that I'm not here to force medication. People don't like medications forced on them. So gaining their trust, gaining that rapport with them, seeing how much it's impacting their life. And when it gets to the point where Mino's saying that it's a danger to themselves or others, that's when we might have to go the extra mile and say, you might need to go into the hospital. And unfortunately, there's